Thanks. Good morning, everyone. Welcome to another High Rounds. It is September 18th, 2020. Dr. Wooten really needs no introductions, but she is just wonderful on so many levels, both professionally and personally for a lot of us. So I'm really excited for this talk. I want to give her her full time. So Darcy, I will let you take it away.
Thank you, Jill.
Sorry, Darcy. Just as always, please put questions in the chat for clarification. I will interrupt Darcy. Otherwise, we'll try to save the chat for the end. Sorry about that.
No worries. Thank you. Thanks, everyone, for joining. And I keep getting a message that I have unstable internet. So if I cut out at some point, please let me know. I have the chat up so I can monitor it as well. This is a little bit of an atypical talk for this conference, but hopefully you'll find it interesting. I'm going to be speaking about sustaining the ID and HIV workforce through medical education innovations. I'm Darcy Wooten. For those who don't know me, I'm the Associate Program Director for the ID Fellowship here at UCSD, and I'm the Director of Education for at Owen Clinic, which is our HIV Primary Care clinic here at UCSD. I don't have any financial disclosures. I'll just say I have a little bit of a frog in my throat, so I apologize again if my voice cuts out during this. So I have three objectives that I'm trying to address today and that I will sort of lay out here as a way of setting the roadmap for the talk. I want to start by reviewing some trends in the ID Fellowship Match, which is a proxy for interest in people going into infectious diseases and HIV. I do want to just acknowledge that working in ID and specifically in HIV, going through ID Fellowship is just one avenue, and wanted to acknowledge that there are other ways to practice HIV medicine, including our advanced practice practitioners, as well as doing an HIV fellowship or no fellowship. Just because of time, I'm going to be focusing on the ID pathway and because of my involvement in the ID fellowship, but just wanted to acknowledge that there's a really important group and area that I'm not going to be focusing on today, just in the interest of time. After reviewing those match trends, I'm going to review the proposed global strategies from the literature about what's been put out there as an effort to attract trainees to our field. And then finally, I'm going to focus in on one of those specific strategies, which is dealing with optimizing medical education as a way to increase interest in ID and HIV. And I'll talk about some of the work that's been done here among some of my awesome mentees. So I'm going to be presenting some of the work of mentees that I've worked with in medical education, and I just want to introduce them and give a shout out to them at the beginning. So in the upper left is Austin Marshall. He's in between his third and fourth year of medical school, currently doing an MPH at Harvard. And he's been rotating with me in the Owen Clinic for the past 3 years. In the upper right is Elizabeth Hasty. She's a third-year internal medicine resident here at UCSD. She's going to be a chief resident next year. In the lower left is Christine Sunners. She's a current R2 in the internal medicine residency here at UCSD. And in the lower right is a current intern at UCSD, Morgan Baraba Haran. He's also a PSTP Future ID Fellow who will be joining us after he finishes his 2 years of internal medicine work here. So let's jump in and review some trends in the ID Fellowship Match over the past several years. And so there's a number of different ways that you can look at trends in ID Fellowship Match. I'm going to be presenting the percent of ID Fellowship programs that don't fill, meaning they have at least one position that goes unfilled each match cycle. Other ways that you could look at this could be sort of the total number of fellowship positions available and how many of those fill each year. Regardless of how you look at it, the trends really stay the same. I'm just trying to keep it simple and keep it consistent as we compare different years. So this shows the trends in ID fellowship match rates, showing the percentage of ID fellowship programs that did not completely fill. And so you can see starting in 2012, we had this increase in the number of fellowship programs that weren't able to completely fill, really peaking around 2015, 2016, where these rates were almost as high as 60%, which was, as I'm sure, is pretty alarming to everybody, and people who were seeing this, it was pretty alarming. Between 2016 and 2017, the IDSA created the all-in policy, and this was a rule by which accredited fellowship programs could only match fellows through the match. They couldn't take fellows outside of the match. And so I think this contributed to those lower rates of programs not filling, but you can see that the rates stay high even after this all-in procedure was implemented. And so the percentage of fellowships that haven't filled between 2017 and 2020 has stayed fairly consistent, ranging from 30 to 40%. So how does ID compare to other subspecialties within internal medicine that have similar fellowships? And you can see we really don't do that great. Geriatrics and nephrology have a higher percentage of fellowship programs that didn't fill. This is data just for 2020, but the trends are fairly similar if you look in years prior. But you can see even some of the other cognitive specialties like endocrine, rheumatology, hematology, oncology, those all have a much lower percentage of programs that didn't fill. And then I think of no surprise to anybody, the procedural specialties like GI, pulmonary critical care, and cardiology have very, very high fill rates and are able to fill almost all of their spots and programs. So the one kind of upside of this, or maybe silver lining, is that even though we don't necessarily, compared to other subspecialties, have as good of a track record of filling all of our positions, we actually do much better in terms of racial and ethnic diversity. This was a nice paper that was published in JAMA just in March of this past year. Lakshmi, who's the lead author on this, was actually my intern when I was a third-year resident at UCSF. And she put out this nice paper showing, comparing all of the different internal medicine subspecialties, what proportion accepted fellows that were from underrepresented in medicine, meaning individuals who are from groups, racial or ethnic groups where the programs there, oops, sorry about that, the proportions don't match what's seen in the general population. And so those numbers are shown over here. Let me just get my pointer here. Okay, so hopefully you can see this a little better. So this shows sort of the total percentage of underrepresented, and you can see this dark blue line, ID, we actually do, they compare it to internal medicine because this is the pool from which applicants go on to fellowship in these subspecialties of internal medicine. And we actually have a larger racial and ethnic diversity compared to internal medicine, as well as compared to all of the other medicine subspecialties. So this is something, and there's different ways that you can look at this and interpret this, but this is something that I'm actually quite proud of in terms of what we strive for in infectious diseases. But I'm sure there's a longer conversation that we can have about the reasons for this. Yet, despite all of this, you know, we're seeing these trends in very high rates of fellowship programs not going filled and positions not going filled in infectious diseases. And this was a nice piece, a blog piece about how the infectious disease physician is really kind of an endangered species. And it's a little bit difficult to understand if you think about all of the unmet needs in ID and in HIV in terms of clinical care, research, and public health. And these are just some of those unmet needs where we really need more people and really sort of some of the best and the brightest to work on some of these issues. COVID-19 really dramatically highlighted how we have, we're very understaffed in terms of ID physician clinical care research, et cetera, throughout the US. This was a piece in the Annals of Internal Medicine that was just produced in June, looking at the number of ID physicians throughout the country. And the average number of physicians per 100,000 is about 1.6. And so in this map, the red shows areas where the number of ID physicians is below that average. The blue shows areas where the number of ID physicians is above that average. And then the white, which is almost the entire map, shows where there's actually no ID physician in that county. And so almost 80% of counties within the US have no ID physician. And when you kind of translate this out to the number of people living in counties with no ID physician, it's about 208 million. So there really is this shortage, and in particular, we sort of have seen and felt this in COVID, and yet we still are not drawing as many people as we should to the field. And so I want to kind of open it up for a little bit of interactive dialogue here, and you can put into the chat, or if you feel strongly and want to unmute, you can do that as well. But which of the following do you think best account for this declining interest in ID and HIV careers, as we've seen as sort of a proxy through lower rates of people applying and matching an ID fellowship? So do you think it's mostly because of salary, lifestyle, lack of exposure to diverse ID career opportunities, meaning early in trainees' careers, they don't sort of get to see and understand the diverse career opportunities that might be available in ID, lack of exposure to ID faculty, or E, lack of ID research opportunity and mentorship early in training? So seeing some A, so salary, also lack of exposure to career opportunities, combination of things. And not to burst anyone's bubble, but there is no right answer to this question. So sorry to not be able to give you closure on that. It really is multifactorial. And obviously for each individual, there's going to be specifics that apply to them. So, you know, the question kind of becomes, well, how is COVID-19 going to impact the field of ID and attracting trainees to ID? You know, if you think about COVID-19, healthcare workers and ID specialists in particular have been sort of held up as heroes. Tony Fauci is a household name now. And there's these events, you know, thanking the healthcare workers on the front line, and people really acknowledging all of the work that infectious disease specialists, many of whom do HIV care, are doing in terms of research, in terms of infection prevention, diagnostics, and that type of thing. And so this was a nice piece done by Morgan, our future PSTP ID fellow, looking at, you know, will the COVID-19 pandemic renew interest in ID? And obviously it's too early to tell, but he looked at internet searches as a proxy to see if there's any signal that there's an increased interest in infectious diseases. And so what he did is he approached this using a cross-sectional analysis using something called Google Trends, which is a program that allows you to compare a handful of search terms and see which of those search terms is the most popular. So he looked at ID, infectious disease fellowship, hematology oncology fellowship, endocrine fellowship, and rheumatology fellowship as search terms. And he compared sort of the relative popularity of these search terms in 2019, before COVID-19, and then in 2020. And he looked at the specific time frame between March and June. So Google Trends spits out this number called the average relative search value, which shows sort of the relative popularity of a search term and then normalizes it by all of the searches that were done at that that given point. So you can't compare the absolute numbers between different time points, but you can just compare sort of the general trend or the general popularity between two different time points, and that's what he did in this study. The RSV is a score from 0 to 100, where 100 would be sort of the most popular search term. So this is the data for 2019, and you can see that among these specialty fellowship search terms, infectious diseases came in third place after hematology, oncology, and rheumatology. So infectious diseases is over here in the green. And this is in comparison to the data that he found in 2020. And so here you can see infectious diseases is now the most popular for this time point based on this RSV value. So I think this is, you know, somewhat hopeful and optimistic. Of course, Google search terms do not correlate to people applying to infectious disease fellowships. And so we'll have to look at the data going forward to see, are more people applying an ID and how many more people actually go on to match and pursue careers in ID. But I think that this is somewhat optimistic and hopeful and not particularly surprising given the way that really people have rallied around infectious disease specialists because of the work that they've done regarding COVID-19. But not to paint things too brightly, I think we need to really ground ourselves and think about sort of what Brad Spellberg points out in this article published in OFID recently, a perspective piece. And here he points out that we shouldn't rely on COVID-19 to fix the issue of shortages of ID physicians. He says that we've had pandemics before, Zika, Ebola, H1N1, and yet we still have had challenges attracting top talent to the field. Now, we haven't had a pandemic like COVID-19 before, but that there's still other factors that, of course, we need to consider, and we really need to sort of capitalize on this momentum and moment, and not just sort of rely on the pandemic itself to attract people to our field. And he points out that the average medical school debt continues to increase. This is a little bit of old data, but in 2015 and 2016, the average cumulative debt at graduation was $250,000, which is quite substantial. And he further points out that ID is only one of two medicine subspecialties where the reimbursement is actually lower than if you don't specialize and practice as a generalist. And so he talks a lot about aligning with market forces in order to change the payment structure within infectious diseases and to change some of the practices, the approaches to practicing an ID in a way that will optimize the reimbursement as a method of attracting people to the field who are graduating with so much medical school debt. So I'm going to go through some of the literature and sort of expert opinion on what proposed strategies are out there to try and attract trainees to our field, because this has obviously been a problem that's been around for several years now. And a lot of the recommendations really come from this key pivotal study that was done by Wendy Armstrong and her group at Emory, looking at factors that influence what subspecialties or what careers internal medicine residents go on to after residency. So this was a study of about 600 internal medicine residents, and what they did is they surveyed the residents at two time points. Once during their intern year before they had finalized on a career and decided on a career path, and then once again at the end of their third year of residency, at which time they would have already matched into their subspecialty, or if they were going to continue in general internal medicine either as a primary care provider or a hospitalist, that would have been determined. I'm not going to go through all of the details of the study. I'm just going to highlight the key findings. So in their study, they found that 65% of residents had actually developed an interest in their specialty very early on during medical school. And sort of tagging along to that same theme, they found that the infectious disease and the microbiology curriculum in medical school, as well as in medical school research opportunities and ID mentorship, those were key factors that influence residents to go into infectious diseases. And then they looked at a subgroup, so the residents that reported during intern year that they were interested in infectious diseases, but then in their third year indicated that they were going into a different field. They said, what was the most important factor that led you to your career path? And salary was the most dissuading factor for this group who had initially been interested in infectious diseases and then chose something later on. So jumping off of this data, they came up with this policy and proposal paper, a white paper of sorts, in terms of strategies to try and attract more people to ID and HIV. And the first strategy is really what I'm going to focus the rest of the talk on, but they talk about innovating and enhancing infectious disease and HIV medical education, particularly very early on during medical school, when people are often forming opinions and ideas about their career path. And they also talk about including opportunities for these early learners to participate in scholarly projects, publish abstracts and papers, and just have more career mentoring. They make mention of including infectious diseases under the National Health Service Corps so that trainees going into this field who want to work in underserved areas can be forgiven their medical student debt. They talk about developing novel programs within NIH for expanded early career research opportunities. And finally, they get at the issue that Brad Spellberg was speaking so strongly about in his opinion piece about reforming reimbursement for the cognitive specialties in general. And that's obviously a bigger talk and subject that could be its own talk in and of itself that I'm not going to focus on for the rest of this. So now let's focus in on one of the strategies to try and increase and attract trainees in our field, and that's optimizing our medical education efforts. And this is what I'm most interested in because of my area of interest in medical education. So I'm going to present data that was still in progress, a mid-study report that was done by Austin Marshall, my medical student who I mentioned earlier. And he looked at whether both a clinically contextualized curriculum that was administered synchronously with a clinical rotation in an HIV primary care clinic could increase interest in ID or HIV as a career. And so he looked at trainees rotating in our HIV primary care clinic here at Owen Clinic, and we have two major categories of trainees. We have third-year medical students who are on their internal medicine third-year clerkship rotation, and they rotate with us weekly for 4 weeks. And then we also have internal medicine residents who rotate with us for 2 weeks at a time. And all of these trainees who rotate through are given our clinically contextualized curriculum. So this is about a 20-page document, and it has these 4 specific features. So it has very concrete and specific learning objectives, as well as clinical skills and competencies that we expect the trainees to walk away from the rotation with. It also goes over kind of an overview of HIV healthcare maintenance, antiretrovirals, and sexually transmitted infection diagnosis and treatment, kind of for the non-specialist. It goes over, again, specific skills that we hope the trainees develop and get to practice while rotating in the clinic, including cultural competency, taking a sexual history. We make everybody watch the video, the wonderful video that Dr. Jill Blumenthal and the AVRC produced on do's and don'ts for taking a sexual history. There's specific reading and tips and tricks for adherence counseling and motivational interviewing as it relates to substance use. And then I think the fourth piece of the curriculum is particularly unique in that we really orient the trainees to the clinic and the staff. Like most HIV clinics, we operate in a very using a very multidisciplinary approach and a very team-based approach with social workers, financial counselors, clinical pharmacists, psychiatrists. And so it's this whole team of people helping to take care of the patients. And so in the curriculum, we orient people, the trainees, to sort of who these people are and what their role is. And I think that gives them a better understanding of how the clinic works and how we care for patients using a team-based approach. And the trainees love this. And I think it's something that's really special about HIV clinics that they don't necessarily get to see in other clinics that they rotate in. And so they also have a better understanding of how the clinic functions, so that when they're rotating in clinic, they can actually do so more effectively. And so Austin did a pre and post rotation survey looking at 3 categories of questions and information that he was trying to sort of suss out. So one group of questions focused on fund of knowledge using case-based questioning, looking at whether or not trainees knew preferred first-line antiretroviral therapy, whether they understood the concept of undetectable equals untransmissible, a question about STI screening, gonorrhea treatment, and syphilis treatment. There was also another set of questions looking at self-efficacy. So how confident do trainees feel in their ability to manage patients with HIV, as well as confidence in their skills to take a sexual history. And finally, this last piece, which is really the main focus, is sort of what is their interest in ID or HIV as a career before the rotation and after the rotation. So I'm going to go through all of the results, but we'll focus in, and I'll go into a little bit more detail about interest in career choice before and after the rotation. So we conducted the survey between July of 2019 and March of 2020. Obviously, everyone knows what happened in March when COVID hit, and we had to actually have trainees stop coming to clinic for a brief period of time. So it was cut short, but we've started it up again. During this time, 31 trainees who were offered the survey, 21 completed both the pre and post rotation survey. 57% were internal medicine residents and 43% were medical students. So we'll go through each question. The first fund of knowledge question looking at whether or not trainees knew what the first line antiretroviral therapy was for treatment naive patients. Before the rotation, 57% got the answer correct, and after the rotation, 76% got the answer correct. I will say for these fund of knowledge and self-efficacy questions, there were no major differences between medical students and residents, so I'm not going to show that broken down data here, again, also because the numbers are fairly small at this point. In terms of understanding and knowing that undetectable equals untransmissible, before the rotation, 76% got this answer correct, and after, 100% got this answer correct. So again, even though the numbers are small, I think this is very exciting and encouraging that our trainees are really getting this concept so that they can counsel their patients about this, as well as family and friends, and really spread the word about U equals U. In terms of STI diagnostics, the question focusing on this topic, 57% got the question correct before the rotation, whereas 78% got it correct afterwards. In terms of gonorrhea treatment, people did really well on this question even before the rotation. It was fairly easy, just what do you treat gonorrhea with? And then 90% got it correctly afterwards. And then we still have some work to do in terms of syphilis, which always tends to be a very confusing and challenging topic. I will say that the syphilis question was fairly advanced and probably at the ID fellow level, but before the rotation, 43% got it correct, and after the rotation, 48% got it correct. In terms of self-efficacy in managing people living with HIV, the percent of trainees reporting confidence in their skills to manage a patient with HIV, 24% reported confidence before the rotation. And I think this is really great, 90% reported confidence after the rotation. Of course, just having confidence in your skills doesn't necessarily mean that you actually have the competencies there. So this is a limit, of course, that this is just self-report. And then in terms of self-efficacy for taking a sexual history, 57% of trainees reported confidence in their skills to take a culturally competent sexual history before the rotation. And this is also really great to see 100% reported confidence in their skills after the rotation. So then getting to, I think the main area of interest, at least for me, was did the rotation with the curriculum change or influence the trainees' interest in an ID or HIV career? And so this shows how people, this is the aggregate data of both medical students and residents, and I'll show you the stratified data in just a second. The light green shows how people answered this question before the rotation, and you can see most people were sort of neutral regarding their interest in a career in ID before, with many people disagreeing or strongly disagreeing. But you see this shift with the dark green in that more people are at least open to the idea and interested in an ID or HIV career after the rotation. And then when we look at this just among the medical students, we see a similar trend. Again, most people were sort of neutral regarding ID and HIV as a career, with some people disagreeing. And then the dark green shows this shift towards more people agreeing or being excited about ID after the rotation. And then I was actually surprised to see a similar shift in residents, because based on the data presented by Wendy Armstrong, sort of assume that residents often sort of already know what they're doing and what they're interested in. But you can see that after the rotation in the dark green, there was a little bit of a shift towards people maybe considering ID or HIV as a career. So obviously, this is ongoing. We're still collecting more data, but there's many limitations to this approach. And I think the biggest one that I worry about is that trainees might inflate their interest in ID after the rotation, because they're either concerned about their evaluation, or they think, oh, if I say I'm interested in ID on the survey, maybe I'll get a better evaluation. We try and reassure them that this is in no way linked to their evaluation. In fact, it's completely anonymous, and the people evaluating them are probably not the people analyzing the survey data, but there's still that potential there. And of course, we'd like to measure actual competencies, and of course, somebody just answering a question or answering a question that they're interested in an ID career does not translate to them actually applying to ID and following through. So obviously, if we had funding and resources, we would like to follow that out to see what people actually go on to do and choose their career, and how they choose their career. So that's that project by Austin. I wanted to change focus and talk about the impact of working with trainees in terms of scholarly projects and providing mentorship, and just provide an anecdote, which this is just an anecdote, but it's a fun story to tell. So this is Elizabeth Hasty. As I mentioned, she's an R3 here currently, going to be a chief resident next year, and she was rotating in Owen Clinic during her second year, and she was interested in going into GI, specifically hepatology. And so while she was on the rotation, she wanted to do a scholarly project. And so we came up with a study, a national survey of HIV providers. Some of you may have participated in it, looking at their hepatitis B vaccination and revaccination practices. She's presenting her data at ID Week and writing up the paper. And through this experience, along with, I think, working with many of our awesome Owen Clinic attending, she's actually decided to apply in infectious diseases as opposed to GI and hepatology. So just an anecdote, but an example of how mentorship and scholarship early on in trainees' careers can potentially influence people to a particular field. And then I just want to finish up by talking about this concept of HIV training pathways within residency programs. So this was a study published in CID, I think just in May of this year, that did a national survey looking at the curricula and outcomes of residency programs that have dedicated HIV pathways. So they found throughout the country that there were 25 residency programs that had a dedicated HIV pathway. 14 of these were family medicine and 11 were internal medicine. Of all the programs, they had graduated 228 residents, most of these coming from internal medicine, 77 coming from family medicine. this is a map showing where these programs are located. So the triangles are the family medicine programs, and this is here locally in San Diego Family Health Centers, which I'll say a little bit more about in just a second. The octagon are the internal medicine programs that have HIV pathways, and then the darker regions as well as the hatched regions show designated county and state areas that are priority areas for ending the HIV epidemic. And I think it's important to look at where these HIV pathway program training programs are, and do they overlap with these priority areas, because we know that trainees tend to go into practice locally where they've completed their training. Not always, but the majority of the time. And you can see that there's not a ton of overlap, particularly in the South, where I think there's the most need for HIV providers. So these were the key findings. Unfortunately, only 39% of the graduating residents from these programs actually went on to continue to provide HIV primary care, which they defined as taking care of at least 20 people living with HIV. This percentage was higher among those graduating from family medicine residencies compared to internal medicine residencies. What I thought was interesting and hopefully a little bit more optimistic than this 39% kind of abysmal number is that those pathways where the primary focus was to train physicians to become HIV primary care providers, which was only about 20 or so, 71% of those residents went on to careers in HIV primary care, taking care of a substantial number of people living with HIV. So there was a lot of heterogeneity among these different HIV pathways, some with just a little dabbling of experience in HIV care, and some with a much more robust experience of having an HIV continuity clinic, journal clubs, doing a longitudinal or scholarly project, etc. And so those programs, which were more intensive and really where the goal was to create HIV primary care providers, those residents tended to go on and actually fulfill that goal. We talked about the geographical mismatch between where the programs are, so 75% of the programs being located in the Northeast or on the West Coast, and how that doesn't overlap as much as we would like it to with those EHE priority areas, particularly in the South. And then when they surveyed these programs asking about what the major barriers were to either creating or maintaining these pathways, the number one and number two barriers were curricular constraints, such as the residents needed to do so much time in the ICU and the CCU and on the wards, so they didn't have as many opportunities to participate in HIV primary care, and then funding was another big issue. So this focuses in on family health centers. Their family medicine residency program has an HIV medicine track, and Dr. Christian Ramers asked me to present some of this information about the local family health centers HIV medicine track. So they have had 13 residents in this track, 8 of whom have graduated. They've all gone on to receive additional certification and are practicing in HIV primary care. They have ongoing mentorship and HIV continuing medical education through PAETC, which is run by Daniel Lee here and Moira Martang. And they've also trained 2 family medicine faculty for 4 nurse practitioners and 1 PA to have this HIV area of emphasis and specialty to be able to add to the workforce. So UCSD has always had sort of an informal HIV pathway or track within the internal medicine residency program. But this year, Stacy Sherratt and I have put together a formal HIV primary care track within the primary care track in the internal medicine residency program. And so the goal of this track is fourfold. So to provide primary care residents with an enhanced outpatient HIV primary care experience. We do want to prepare trainees to pursue a career in HIV primary care, which may or may not include an ID fellowship afterwards, an HIV fellowship afterwards, or none of the above. It all really depends on the specifics of the trainee, how much experience they get, and really where they end up practicing and kind of what additional types of support and ongoing educational activities they have. We're mentoring residents in this pathway in a longitudinal scholarly or quality improvement project, and then we also want to expose residents to the subspecialties within HIV medicine. So this is an outline of the structure of the track and kind of describes the clinical experiences and research experiences that residents in this track would participate in. During their intern year, they would do 2 weeks on the inpatient HIV medicine consult here at UCSD and then rotate in Owen Clinic for 2 weeks. In the second and third year, they would do 6 weeks of Owen Primary Care Clinic, as well as 2 weeks of subspecialty clinics in Owen, kind of scattered by various half days during their other primary care blocks. In their second year, they would start a quality improvement project within the Owen Clinic, as well as participate in our self-directed ID Fellow HIV curriculum. And they would work on their quality improvement project as well as the HIV curriculum over the second and third year. And in the third year, they would publish and disseminate their scholarly work. So Christine Centers is our first resident who's in this formal HIV primary care pathway. She rotated with us last year, and she'll be, of course, rotating with us over the next 2 years in Owen Clinic. She's still nailing down the specifics of her quality improvement project, but is probably going to do something on diabetes healthcare maintenance for people living with HIV who are seen in Owen Clinic. So this is all, very much in the beginnings, and I hope that we're able to build and expand upon this because I do think that looking at more alternative approaches and routes to increasing people who go into the HIV and ID workforce is very important. And again, as I mentioned at the beginning, I haven't included anything about APPs and sort of their role in terms of increasing HIV primary care providers. That's a very important and substantial area. Just for the sake of time, I didn't have time to go into it. So I want to just end with some concluding remarks. Maintaining and increasing interest in ID and HIV careers is very much a challenge for many reasons that we've laid out from the beginning. I do think that there is a silver lining of COVID-19 and that it is going to generate this renewed interest in infectious diseases, but I think we need to be very strategic about how we capitalize on that interest and really kind of strike while the iron is hot, but simultaneously continue to pursue reimbursement reform and all of these other things so that it's not just sort of a one-year flux and increase in ID fellow applicants, for example. And then I think as ID and HIV physicians, scientists, clinician educators, we really have imperative, a moral obligation to our patients to try and improve and mentor and teach, do scholarly projects with early trainees, because we know that interacting with trainees in a positive way early on in their career really does have the potential to influence them, at least has a component of influencing people to enter the ID and HIV workforce. We, of course, need a multifactorial approach to address all of the other issues that have been laid out, but I do think education and education interventions are going to be helpful in terms of influencing people to join the best fields within medicine. All right, so thank you for your attention, and I'm happy to answer any questions. I don't know if there's been much in the chat or if anybody wants to unmute for more of a dialogue.
Thanks, Darcy. There were a couple of really good comments, and instead of reading them myself, it would be great if the people who said them would unmute if they could. Dave, are you available to speak about the self-efficacy finding? which obviously, Darcy, you can now see. Okay, perhaps not. So I will read it as if, so the self-efficacy for treating people. Oh, there we go. Thanks, Dave.
Sorry. Yeah, no, I actually was really struck by the self-efficacy question that you did in the pre and post Owen rotation survey. And it went from like 24% to over 90% of people who thought that they would be able to care for a person with HIV. And, you know, on the one hand, I think relative to your talk, I would wonder if that meant that, you know, having a good educational experience in HIV, either as a resident or a medical student, kind of demystified it a little bit and would make it less likely that somebody would feel that they need to be an ID specialist to actually take care of a person with HIV, which I would kind of agree with, I mean, to be honest. And then, not that we don't need people who are ID specialists, because there's obviously a lot of other stuff that needs to get done too. Anyway, but the other thing that I thought, and I was wondering if you guys had any way of looking at this, or maybe building it into a future study, is how does that compare, I guess, to other conditions? Like, do people have the same degree of doubt about their ability to take care of other groups? And is it something special about HIV? And I wonder if it just relates to just all the general stigma about HIV, and the rotation itself was very destigmatizing, demystifying, and allowed people to kind of realize, like, you know, that people with HIV or in HIV itself isn't that scary.
And those are all great points. I don't know of any data that's looked at, you know, other populations or other disease processes, and sort of after doing a clinical experience, how that changes people's approach. I think your comment about stigma and destigmatizing things, I think that's absolutely, you know, obviously I don't have the data to actually support that, because we didn't sort of dig that deep on that question. But I think that's what's going on. I definitely think that that's at least a large component of the explanation for why we saw those numbers.
Minnie Aldous, or me, I think it's Nina Aldous, sorry, who's actually Nettie, I think put a really good comment in the chat. Nettie, are you able to unmute yourself and share this comment?
I don't know. I'm on Nina's computer. Let's see. Can you hear me?
Yeah.
Yeah, I don't know how she got it all programmed for her. That's what happens when you have teenagers. So I was just, you know, we've been training the internal medicine residents in our clinic for 6 years now or something. And, you know, they are really, you know, HIV care is mostly primary care, and a lot of people don't want to go into primary care. And so one of the other things we could be doing is making our healthcare system more attractive for primary care for all people, all doctors who are interested in that kind of work. But, you know, in internal medicine, it's really hard to pull people into primary care, period, right? Because the opportunity cost is so great, and primary care is really, really hard. So, you know, the family medicine residents, they're at least kind of primed for primary care. They came into it interested in it. So when they get to HIV clinic, they're used to all the primary care stuff in HIV clinic, and they're really interested in all the wraparound and the team-based care, and they you know, care about social justice. And so they're really a great group to get into HIV care. So I think if we're trying to expand, I mean, I know this is a different topic, but if we're trying to expand the pool of people who can provide care for our patients in the future, people who are good at primary care, who care about the issues and are trained, you know, appropriately for HIV, family medicine is a good group to target as well. And we've had pretty good success with them, and then they can go on to subspecialty family medicine training for HIV. So I think that's important. The one thing is that we can't abandon internal medicine because they don't quite have as much training with the really intensely sick people. So a small percentage of our patients, but still an important one that come in with HIV and TB and an OI and whatever. I think we still need to have some, a breadth of providers in HIV so that people who fall into that category can still have access. But for most of our patients, a good HIV trained family medicine doctor is great.
Absolutely, and I think that was Stacy Sherratt and I's kind of rationale for let's create this HIV pathway within the primary care track that already exists within internal medicine. So this is a track in the internal medicine residency program for people who want to go into primary care, and then more specifically HIV primary care, because like you said, so much of HIV primary care is primary care. And I completely agree with your breadth comment in terms of needing to have a variety of people with various skills for those, not common situations when you have a really, really sick patient or very complicated patient from an ID perspective to get that input, or, be working in a system where you have that backup and support for those cases.
I will also add that, like, when we're trying to do our mentoring, the family medicine folks, a lot of them are really interested in LGBTQ care or want to do transgender care along with HIV. They get very limited exposure to ID docs, because if you look at that map you put in the beginning, all those areas that are white where there's no ID docs, a lot of the family medicine training programs are there, right? Rural communities, or, and so there's a real mismatch in them even getting to meet someone to show them that they could be doing this.
Yeah, it's a great point.
Same for internal medicine primary care tracks too, right? They often aren't located in places where they get to meet specialists.
Yeah, great point.
Darcy, I had a few thoughts. I think a lot of people have shared some of these here. I'm going to share my video. Again, in terms of focusing on internal medicine folks, outside of what's already been shared, I think a lot of people do go into internal medicine because they want to use, there is the draw of a procedure, which a lot of the subspecialties offer that ours does not. And there are some people who really do want to be dexterous and use their hands, and that is just an automatic turnoff for ID, where we do a lot of talking and thinking, which obviously I'm preaching to the converted here. That's what a lot of us want to do. But there are some people that just really want that mix, or really a predominance of procedures. So, when we draw from internal medicine in total, I always think there's a group of those people we're really not considering them at all, because it would never cross their minds to just do something where it was mostly just engaging and talking. I think, sorry, that was just one comment. I had other things to say, but I think a lot of people are sort of bringing up important things. I think Chris Matthews brought up a really important point here, again, about the shift to chronic disease management away from what may have drawn ID doctors in initially, and those, when people were really sick, which of course we still see. And I think anyone who's rotated us on the Owen inpatient service knows that. That's a lot of what we're dealing with. So you really can get that, but it's obviously a much smaller piece of what we're doing. And so how do you think that's affected who's coming into HIV care?
I think it's definitely impacted things. And I have an anecdote of a specific fellow that I'm thinking about who initially was interested in doing HIV because of that person's experience during residency of taking care of really sick patients with HIV in the hospital, but then getting to the clinic setting and not really liking the sort of slow and complicated pace and of primary care, and then ended up switching to focus on transplant ID because of that sort of acute, very critically ill with opportunistic infections patient population. So I think that does, that definitely has impacted it. Obviously, that's one example, but people, considering that type of career. And I think for people, Paul Sachs did a nice a blog a couple years back talking about seasoned physicians in HIV medicine actually leaving, either going to industry or retiring because of that change in focus, talking about a seasoned HIV physician who didn't want to treat chronic back pain in clinic. So you do have to, thinking about sort of what we do on a day-to-day basis in terms of managing mental health issues, substance use disorder, chronic medical conditions, et cetera. You do have to, I think, attract people that are interested in those types of areas. But I think it has to be coupled with, the support and the resources and the training to be able to do those effectively. Because I think people think, oh, a patient with chronic back pain, like that's not exciting and it's going to be complicated, but I think that's because, right, a lot of the systems in place limit kind of what we can do. Insurance isn't going to cover physical therapy, for example. So I think, it requires both targeting the right, trainee population, but also a huge change in the system. And I was thinking about your comment about, people that want to be proceduralists because they want to do things with their hands versus talking to patients. And I really wonder if it's a chicken and an egg type of thing, because people know that when you do procedures, you make more money. And so do they really like procedures, or, is there any subconscious bias that, the procedural specialties will be associated with potentially a better lifestyle and definitely more compensation? And how do you sort that out?
Yeah. The other thing I was thinking about, because occasionally in our clinic, and forgive me for not knowing this, I think, know how the educational, how that's set up. But, we're often with third-year residents who have they're long past having to make that decision. So, getting, if we really want to see how this impacts what decisions people ultimately make for their careers, we'd have to have first and second years exclusively, and third years really, if they were just sort of polishing up what they wanted, or just saying, I want to take a turn in this because I know it's important for me. But, asking a third year, we're with one right now who's already knows exactly what they're doing. So obviously that's past the point. And if we are going to use these programs to try to introduce ID earlier, it's got to be done earlier and not, later in residency.
Yeah, absolutely.
Darcy, it's Robert. Great talk, and thanks for allowing the time for discussion as well. A lot of interesting points and ideas. A comment and a question, just sort of piggybacking on at what everyone's saying about procedures. We all know ID is hard too. I mean, let's not forget how those 2 weeks on ID and, our really complicated hospitalized patients burn us all out, and I think residents, can see that as well, compared to, say, focusing on a single organ or, organ system. So, that's part of it, I'm sure, too. The question I had was just about those programs not filling. Real quick, is that possibly a function of, there being more fellowship positions? I know that's true in Los Angeles, let's say, ID compared to rheumatology or some of the others. There's more programs, et cetera. Just briefly on that.
Yeah, there is a difference in, the absolute number of positions between the different subspecialties. I don't know if I would say that there's too many ID fellowship positions, though, because sort of as one of the slides that I presented, there's this huge unmet need in terms of needing more ID physicians, at least in my humble opinion. So I think we do have a need, and those entire counties and parts of the country that don't have any ID physicians, I think there is an important need there. And it's more about attracting people to the field than having just too many positions. There's definitely a mismatch, and maybe there are too many fellowship positions, but I just feel like there's too many unmet needs to say that we should cut back the number of fellowship positions. I don't think we have enough ID physicians as it is.
Good, thanks.
All right, well, it's the top of the hour, about to be the top of the hour. This was wonderful. I feel like if that's Aaron Wilcott, I always feel like he throws in a great question just as it's becoming 9 o'clock or the end of it. I don't know if you can tackle this really quickly.
They don't do primary care. Generally speaking, ID physicians will do just the ID issue in clinic. It's different. I did Hep C clinic, and when I was seeing people just treating their Hep C, I would try and get them plugged in to see their psychiatrist and get them plugged into substance use treatment. So I think there's a different, people can approach it differently. I think generally speaking, ID physicians don't do primary care, and they definitely don't prescribe pain medications.
Very true. Agreed. All right. Well, with that, everyone, thanks. Darcy, what a great talk. I think we'll all be chatting and maybe tweeting about it or whatever else we're supposed to do. And to the soon-to-be fellows, hope you enjoy your interview day. Good luck. Make sure you ask good questions. Talk to everyone or see everyone next week. Bye-bye.
Thank you.